Good morning, everybody. Welcome to Incredible All India Institute of Medical Sciences. Can you hear me?
Yeah, Dr. Balaram, I am Dr. Mishra.
Yeah.
Good morning, sir.
Okay,
we can hear
Thank
you well.
Good morning, Sandeep. Good morning, Srinivas. Good morning, Dr. Somaraju. Good morning, Marty Leon and Srinivas. I think it's an excellent meeting. After this excellent lecture by Marty Leon, we are going to go ahead with the demonstration of probably 2 or 3 cases. The first one will be osteal left main, and the second will be a percutaneous Brock procedure, which we will describe you a case in a box. And then we will, if time permits, we will have a case of in-stent restenosis. So before we start that, let me introduce to my colleagues. On my right is Dr. Sandeep Seth. He's our AIIMS expert and also our heart failure expert. And Dr. Sandeep Singh, who is a God-gifted man in terms of handling the wire. I mean, if you give him the wire, he will put it in one ear and take it out from the other ear. And then we have Dr. Karthik behind us. He's our evidence-based man, and he will not let us do left main up till now, unless it is osteal, unless the syntax score is low, and he will not allow it. So there's a lot of peer pressure as far as an evidence-based treatment here. And Dr. Ramakrishna, who will be presenting the percutaneous Brock procedure. He's our pan-cardiologist of the institute. And then we have Pradeep on the cine, and Mangal on the pressure, and we have our 2 male nurse, Biju and Rupi, from helping us with the case. So we are just starting the case, and we've got the sheets in, and we can have the profile of the patient on our PowerPoint. So this is a 65-year-old gentleman who is a diabetic and a hypertensive, and he's on oral hypoglycemic agents. He was asymptomatic until January of this year, and then he developed unstable angina with some ECG changes in lateral territory. It was managed conservatively, and more recently he's having angina exertion class 3, and his left ventricular function is normal. He has been taken up for an angiogram about 3-4 days back, which can we have the angio clippings? So there is a tight osteal left main, as you can see in this RAO view, with the clean LAD and a clean circumflex with some mild disease in the first OM, which is not significant. Next, please. And here we can see in the LAO cranial view a tight 99% osteal left main with minimal calcium, no thrombus, no tortuosity, and no distal lesion. It's just confined to the ostium and initial part of the shaft. Next, please. And the right coronary injection shows about a 15 millimeter lesion in the posterior descending artery. So we're going ahead with the left main. Any thoughts, any questions from the panelists?
So what is the strategy that you are going to, what is your plan?
Yes, the strategy that we plan to do is to take a Judkins 3.5 guiding catheter and cross with a wire, a medium support, medium balanced middleweight sort of a wire, and pre-dilate with a balloon, followed by stenting. And then following the stenting, we will do an AIIMS to see whether it has been deployed well or not.
Hi,
so I think we'll just go ahead. So we have the guiding catheter. We're just going ahead. Yeah, we're going, please, yeah. Can we go ahead and push the guiding wire?
Dr. Sushil wants to say something.
Yeah. What were the discussions with the patient? This is one of the challenges we face in the U.S. In terms of options, what were the discussions?
Yeah, we have explained the patient about the surgery. We've calculated this. We've calculated the syntax score. The syntax score is about 13, and this becomes a 2A indication with level of evidence B for doing this osteal left main. So, and the patient is convinced that obviously anyone would want a percutaneous procedure. I agree from your point of view there is more legal issues, but we are fortunate in that way that we are still able to practice some amount of paternalistic medicine.
Actually, you know, in our center we have a cardiac team approach. So this is my center too. So there we have some surgeons there we have the, of course there are no referring physicians, patient come to us directly, and, so we have a team of cardiologists, we have surgeons there, and we discuss every patient and keeping the patient's view in mind. This particular patient I know about is, particularly keen about angioplasty and, not keen at all for surgery. And anyway, we discussed with surgeon, looks to be a rather straightforward case, so that is the thing, I think.
Balaram, this is Ajay.
There is no straightforward left main, but there is no straightforward left main. Yeah, go ahead, Ajay.
Good to see you. So this was a case that initially the diagnostic was done radially, and then you elected for femoral approach on the intervention, or how did you think about those strategies? Because as you know, we in the States are learning from our Indian colleagues a lot about radial PCI.
It was an elective angiogram. Elective angiogram. We did not rush. Yeah, it was an elective angiogram. The patient was stable. We did not rush him, but we did keep him in the hospital, and we kept him for the case to be demonstrated today.
And the elective angiogram, was that done radially or femorally? The access site?
Yeah, it was femoral.
We do radial, but it's much less. Femoral.
And do you, for left mains, typically use JL guides or EBU guides, or how did you think about the guide selection? Because I think that's an important part of this case.
Yeah, that's a very important question, and I think it's an important learning point for everyone. We liked, particularly ostium and shaft, I think we have to use a JL guide, and we like to use a JL guide. Can you give a test? Because if we use an extra backup, we will probably raise the plaque. So that is one issue which we are really concerned about.
Yeah, so for the audience, I think that the two issues are, one is an extra backup guide can give you great support, for instance, if you wanted to treat the occluded circ, but you can lift something up when you go in. But additionally, then to remove the guide, to essentially place the stent at the ostium can be somewhat more challenging unless you use a JL guide. In this case, I'm not sure of the size of the patient, but it almost looks like this guide may be a little bit large for this patient. But I think the use of a JL guide for osteolesions is something that many operators like doing.
Yes. Okay. Yes. Yes. Okay. I think we are having difficulty.
So maybe Sandeep, while he's working, do you want to comment on the use of the pacemaker in this case? And used for potential support? Is this something you feel necessary, not necessary? Both pacemaker and IABP? If you had to do the case.
Hello, Carl.
Sorry?
No, the use of the pacemaker, the transvenous and then also support, because for left main, it often comes up, operators don't know when to use a balloon pump, when to use a pacemaker. How do you think about that?
Usually when we do left main, we try to keep a IABP standby, that is, not in this case, but many of the cases we prepare the left groin and keep the sheath there in place so that, if you have to put an IABP, you quickly are able to do so. And as you see this, this pacing wire, we keep inside the groin, and if needed, we just take it and put it in the right place. So that way it does not obstruct also, but we have, if we want, we can quickly get in there. That is the basic idea.
I think one thing is this looks like a fairly straightforward case, and if the LV function is preserved and the hemodynamics are normal, just getting access on the other side in case you have troubles with a four French sheath or something, and going ahead and being ready to go on support if needed is also a reasonable strategy.
Yes, in this case we have got a sheath and we've got a pacing lead in place, and we have got a sheath on the left side. Because it's a live case, we have kept a pacing lead, and we have also got a sheath on the left side and a balloon pump on standby. So we've got the wire across, and we are taking a 2.5 into 10 balloon.
In your cases, Dr. Ajay, do you use these kind of strategies, or you would, what do you do exactly?
Just go ahead and dilate.
Yeah, so what I think we would base this on is two things. One is what the left ventricular function is like. In this case, the ejection fraction was normal, so I don't think many of us would we would not put in IABP in that situation. The other issue that can sometimes impact is whether the right coronary is occluded or whether the right coronary is open and how much territory that supplies. Again, for an osteal case, I don't think many of us would put in an IABP. And as far as the pacing wire goes, we would rarely use that only if we were going to do rotational atherectomy for the most part.
Yeah. Even we don't use, I think, because it's a live case, as you said, so he's sort of taking extra precaution. But anyway, whenever we use wire, we keep it inside the, just beyond the groin, and, so that you can quickly place it if necessary.
Take an angio. Go ahead and take an angio.
But I think venous access is a reasonable thing to have if you need to give vasopressors or otherwise, or put a pacemaker in. I think the other issue is that in these cases, we heard Balram mention he was going to use IVUS afterwards. We typically, for left main, with some exceptions, will try to do the IVUS ahead of time. This is one of the exceptions because the lesion is tight enough that if you were to put the IVUS catheter across, you can get ischemic. So I completely agree with this strategy of dilating first and then assessing.
And I think an important point is there was a very quick inflation when you're doing osteal left main or in the left main, doing up, down, quick inflations. Balram, did the hemodynamics change at all when you did the balloon at all? Were there any changes in the blood pressures?
Yes. There was a fall in the blood pressure. Yes. Right now 150 systolic. It went up to 120. But we did a very, very brief dilatation, 10 seconds or so, with a 2.5 into 12 balloon. And now I'd like to ask the house, what size of stent? We are thinking of a 4 into 12, because 8 would have a tendency to slip, and the left main has a tendency not to buy stents.
I think that's a very reasonable strategy. I think 8s for the left main are too short. With the 12, you're going to go across the circ, but that was the ostium of the circ. I didn't see the initial pictures, but does not appear that diseased. In terms of the one important point is finding a view that opens up the left main as much as possible, because you're going to want to hang the stent out, and you need to identify a view that sort of shows you the ostium as perpendicular as possible. And there are different tricks that some people have employed, such as putting a second wire in the guide that sits in the aortic cusp, and that allows you to sort of, by advancing the guide, help identify where the true ostium is, because that wire in the cusp will keep the guide from going in.
The other thing that can be used is if you use IVUS at this point, which is actually could be helpful not only for sizing the stent, but also giving you a distance between the origin of the circumflex and the ostium of the left main and any disease over in those areas. And then with the IVUS catheter positioned in the ostium, you can stop the pullback and do cine to determine what the best view is, or at least what the orientation of the ostium is in a particular view. And then that can enable you to place it in an accurate way.
Exactly. I think that's a very important trick. I think you take a IVUS and you keep it drawing at the point of ostium, you take a cine, so that you exactly know where the ostium of left main is.
And I think if you're going to use IVUS after, it's very reasonable if you're ready to use it just to identify, as I just said, this vessel size, stent length, and to see if you're going to go across where the stent will land.
Now, the other thing that many people would discuss in these situations is when you have a distal lesion in the circumflex, for instance, and if you were planning on treating that, what's the order in which you should treat these lesions? Should you treat the circumflex first or the left main first? And we will generally default to treating distal disease first, except in a situation like this where the ostium is very tight. Because if you can stabilize the ostium of the left main result, especially given that Sushil asked if you got hypotensive during the procedure, the patient did not tolerate it that well, you stabilize that first, and then you can typically work more distally because you won't have issues delivering stents. If it's a bifurcation lesion, then it's a different story, because sometimes when you impact the bifurcation, it may be hard to deliver beyond that point, and you can bend the stent and cause other problems.
But what about now? Suppose there is a circ lesion. I think there is a mild one, but suppose there is a significant circ disease. Now you have done the balloon angioplasty of ostial left main. Now do you plan to do a circ if it has to be done? Or you will still stent the left main and then go for circ?
It depends on, I think, how you feel that day. If it's a nervous day, you put the stent in, you feel comfortable and go. But most
personality of the time,
issues. Most of the time, if you have a good result and it's stable, then you can go ahead and work distally. And even if there's a problem, then you can quickly stent the left main.
Okay.
I mean, in that scenario, if you're going to work through it, it might be reasonable to take a guide with side holes as well, because at some point, as you're working in that circ, if you haven't stented that left main, you're going to dampen. And obviously, you're going to end up using more contrast and things like that. But if you're going to plan on working through that disease before stenting, I think using guided side holes would help.
Another thing, Sushil, what do you think about side holes? You know, there is some controversy about side holes guide being used. So what is your feeling about it?
I mean, I think if we're treating osteal disease, I don't think you need it. And it's going to, impact your quality of your injections as well. But, in rights primarily, rarely in the lefts do I use side holes. I guess you have the stent in place there, so why don't we
run?
Yeah. So this is, what stent is this?
Dr. Balram, what stent is this?
Yeah. This is a 4x12 cobalt chromium. It's a 4x12 cobalt chromium DES in a resolute integrity. So you want a caudal view? Yes. LAO caudal, please. Yeah. Okay. And we have the view is have the stent sitting at the right spot, and now we're doing a caudal view just to get a cine.
Can we go back to the fluoro, please?
Okay.
So, Ajay, can we go back to the fluoro, please? Thank you.
What stent is it?
I think, Ajay, you are right. We are 12. Yeah. Test.
This is important, confirming being at the ostium in two views, and I think that's a very important factor. If you have two good views,
the stent is inside the marker. Test. I think we'll have to go for a shorter stent.
Yeah, that's fine. I think go for the shorter one.
You have the 12.
8 or 9? This is integrity, right?
Yeah,
integrity,
we will go.
Resolute integrity?
We have 10, we have 9, and we also have, This was resolute integrity, yes.
So
now we see what we
have, I think, 9 in this.
9 resolute integrity.
Yeah, it should come smaller. I think the issue is in general, we try to avoid short stents in the ostium of the left main. But I think in this case,
exactly,
you can do it, especially if it's a 4.0 and if you go up high. The big problem people get into with the left main and stent embolization is if it's at the ostium and you take a 3.5 stent, you don't deploy it at high pressure, then with manipulation, the stent often migrates and you can find it on your wire or in the guide or elsewhere. I think in this case, a shorter 4.0 stent, if you deploy it at 12, 14 atmospheres, it should be okay. The other alternative, as Sushil mentioned, would be to cross over the circ. And I think this is where sometimes if you have the AIIMS ahead of time, it can be helpful because then you can determine how much disease there is at the circ and would also give you a distance load calibration of the length of the left main.
Yeah, do you want us to do an AIIMS just now? Or I was thinking that we do an AIIMS after the procedure because 12 is definitely long and the only thing that we have is a 9. So we could put a wire in the circumflex and position, but I think we're okay. But this is a 9, 409. Cine? Okay?
Yeah, looks better.
This is definitely not at the bifurcation, and we are going to take a LAO cranial,
and one
epicranial sort of a view to position the proximal end.
Yeah, and I think generally for left main, everybody likes to look at the diagnostic angio and the LAO caudal, but I think in terms of stent placement, oftentimes it's very difficult to locate it in the LAO caudal.
Pull it slightly.
And so these cranial views are not typical left main views, but they can actually be very useful.
No, we have to pull it, sir. Pull it more. Pull your guiding also.
Test.
Pull your guiding.
The question about the AIIMS, I think that cost is obviously a consideration, and so
I think I would like to ask the panelists to discuss a little bit about the osteal positioning devices and where do they stand. So if you could discuss on that about osteal positioning devices. Test.
I mean, I think that there was initially a lot of enthusiasm for these types of devices. The issue, though, is can you use a variety of other techniques, including image guidance, including wire guidance, as Sushil mentioned, to replicate the results. And I think that's ultimately been the difficult part of some of these devices, is to show that on every case it can work and really make the case simpler, or can you get away with doing other things. So that's sort of my take on these types of devices, because again, you're incurring more expense and you need to show efficacy for that expense.
What about the Osteal Pro, which is being developed by Merit Medicals, and I think Fred Khosravi, a friend of Marty, is working on it.
Yeah, I mean,
they are planning to sell it in the Indian market soon, but the Osteal Pro.
Yeah, I mean, the uptake has not been that great in terms of the United States use of this device. It essentially uses fluoroscopy as a way of identifying where the osteum is, and you can pass your equipment through the device itself.
Let's see in epicranial. If it's fine, we'll deploy it.
The patient is holding up well. I think that pre-dilatation was very good for him. Sine.
And what anticoagulation have you used for this case?
I think we are pretty well placed.
What do you say, the panelist?
Yeah. We've just used heparin.
Heparin, okay.
Deploy. And we've preloaded him with aspirin clopidogrel. Yeah, go ahead. 2, 4. 10, 12, 14. 16. The patient is complaining of pain.
Some ST changes.
And there are some ST changes. The pressure has gone down to 90 systolic. And we did that up to 14. What did we do? 16?
Take out the balloons.
No more?
Take out the balloon.
You want to do a flare? Now, any point about the flare? Does anyone talk about, should we flare up in this, or with the same balloon, or?
I think it's
what
reasonable
is,
to do.
What about the wiggle? And let's flare it.
Yeah.
Did the hemodynamics recover when the balloon came down?
No.
8, 10.
So the pressures are back now.
Yeah, he recovered. Yeah, he's fine. Pressures came out. I think you have a live pressure there.
So for the audience, if you're doing this in clinical practice, the two things is to, number one, minimize the ischemic time, and second, particularly if the ejection fraction is low and you're worried that they can get into a cycle, some people will actually pre-treat with drugs like phenylephrine or neosynephrine prior to inflation. It's not necessary to do, but if you're worried, then you can prevent an ischemic spiral. The reason I asked about the anticoagulation is you want to make sure the ACT is good at the time, because if you're sitting with a stent in the left main while you're positioning and you're not adequately anticoagulated, you may get hypotensive, then that can be a nidus for thrombosis. And again, if we're going to do as well as surgeons, we have to make sure that every case we do is as safe
as we can be. That could be a spiral, which would be a disaster.
So your plan is to AIIMS now?
Yeah, Sine. Yeah, we will do an AIIMS. First, let's take an angio picture with Sine. Yeah.
So you want to post-dilate or do AIIMS first?
What is the house field? Should we do AIIMS first or post-dilate, or what is the?
We can take
Looks just a little concerned about the origin of the circ now. Is that I didn't see the angio prior, but is the patient complaining of pain? Look, the hemodynamics look good, but is the patient complaining of pain?
No chest pain now. The pressure is back to 160. No ECG. Yeah.
It's difficult to see from here, but the circumflex looks okay.
I like to keep it short and simple and not go ahead. And personally, we don't believe. Yeah, personally, we don't believe too much in the bifurcation for the left main. Yeah. I think we'll go ahead with the IVUS and get back to you with the pictures. In the meantime, we'll show you a very interesting case which is being presented by Ramakrishna. And that is a case of a percutaneous Brock procedure, and that would probably interest Marty as well. So I'll hand over the mic to Rama, and he'll talk about it.
Thank you.
Yeah. Up look. Yeah.
Can you hear me?
Yes.
Can you hear clearly?
So I'm going to present the percutaneous Brock procedure. Can you hear me?
Yes, please, go ahead.
Yeah, we had a 25-year-old female. Yeah, we had a 25-year-old female who was first time ever diagnosed to have a congenital heart disease when she was pregnant. She had a class 2 symptoms during pregnancy, and she was diagnosed to have valvular and infundibulum PS, pulmonary stenosis. And entire pregnancy and delivery was uneventful, and she was taken up for a pulmonary valve balloon dilatation 3 months after the delivery. Next slide, please. So echocardiography clearly showed there is a tight infundibular narrowing along with a valvular narrowing. So many of the time we end up doing a pulmonary valve balloon dilatation and wait for the hypertrophied infundibulum to regress. If it regresses, we leave them alone. If it doesn't regress, we end up doing surgery for that. So with the same plan, we went ahead and did a RV angiogram. You can clearly see the hypertrophied infundibulum along with the valvular pulmonary narrowing. Next one, please. So we did a 22x5 balloon. Post BVD was done. Post balloon dilatation, the RV pressures became suprasystemic with a clear-cut double-peaked RV trace and increased gradients across the infundibulum. Now the valvular narrowing is relieved and the gradients are now maximum at the infundibulum. So she was given IV beta blockade. Next one, please. And then she was started on beta blockers. So she was on medical follow-up. And at 4 months later, the echocardiographic gradients are around 150 mm of Hg across the RV infundibulum and with a normal RV function. Next. She was advised surgery. But a young female, she wanted to avoid surgery at all costs. So we started thinking, what if we knock off the excess muscle? Can we safely do it? What is the blood supply of that excess muscle? And which is the safest method? Can we use a coil or a gel foam? But after a lot of thought, we planned for an alcohol ablation of the coronal artery supplying the hypertrophied infundibular muscle. Since it's a novel procedure, there are a lot of challenges and concerns. One is efficacy, whether it will be efficacious, whether it is safe. Since surgery is an established procedure, since 1962 surgery is happening, and nowadays with very little risk. And what are the procedural complications? Will there be conduction blocks? Could that lead to a perforation of RVOT? And what will be the long-term results? Will this narrowing, even if it is relieved acutely, will it recur again? And what about long-term risk of arrhythmia, blocks, as well as ventricular tachycardias, since we are going to leave a scar? So after taking an informed consent and a lot of discussion with the family, we took up the case. And this was the pre-right ventricular pressure. The pressures were systemic, nearly around 100 mm of Hg, the RV systolic pressure. And this was the diagnostic right angiogram, where you can see a small coronal artery arising separately from the right sinus, which is going towards the RVOT. So we had 3 catheters, 3 venous sheaths, one with the RV and RA pressure simultaneous, and one where TPA was inserted. And we hooked the right with a RF 6F JR 3.5 guiding. And coronal artery, since it had a separate origin, we placed a wire in the RCA, and the coronal artery was entered with some difficulty with another wire, which was wired with the 014 BMW exchange linked wire. And we got into the branch of interest with a 2.5 into 12 OTW balloon. Next, please. So you can see, as we can see, like now we have a RCA guiding in, and now we have a balloon inside the coronal artery, which is occluding it, and an injection is made into the coronal artery, and that is staining the myocardium. And simultaneously, a RV injection was done with a Berman catheter, and that you can see clearly that is matching with the narrowing. The area that is stained is matching with the narrowing that is being produced by the balloon through that. Next one. So one thing clear, like this is a very important thing that gave us confidence, because it's a novel thing. We don't know whether we will be occluding the right vessel or not. So you can now clearly see both the infundibulum muscles were being stained with just a contrast. So this injection was made through the balloon, with an inflated balloon. Next one, please. So even this was confirmed on echocardiography. You can clearly see the hypertrophied infundibulum muscle being stained with enhancing with contrast. So after this, then meanwhile we were monitoring the RV pressure. RV pressure started to progressively fall. So we gave 1 ml of alcohol was injected into that branch of the coronal artery. Next one, please. So there was chest pain. The gradients reduced by 50%. There was a sudden shot up in the systemic pressures. The RV became half systemic. As you can see the trace here, the RV came down to around 50. When we started with the 100 systolic pressure, the systolic pressure rose to around 150. But there are no changes in ECG. And in the CCU, when she was monitored, there are serial increases in CPK, CPK-MB. Next one, please. And this was immediate post-procedure. The gradients crossing around 80 by echocardiography became roughly around 40 by echo. Next one. So she had an uneventful recovery. She was discharged on day 2. And 2 weeks of follow-up, she is asymptomatic, and Doppler gradients across the RVOT is only 40 mm of Hg. So maybe percutaneous alcohol ablation of coronal artery is feasible and may be effective. And this strategy may be an alternative therapy to surgery in selected adult patients with double-chambered right ventricle also. Next one. Thank you.
Bolo. So I think Rama is ready to field any questions that you have.
I was done.
Just a couple comments about the case. I guess I've never seen that procedure done. Obviously, I've done alcohol ablation of hypertrophic cardiomyopathy. I guess it's a similar concept, and I guess the concerns are similar in terms of too much injury, heart block, perforations, and I guess the catheter slipping back and creating an RCA infarct. How often have you done that? And the surgery for it? I don't treat much congenital disease.
Rama, would you like to answer? Yeah.
Yeah, this may be the first case done as an elective case in the world.
And we have done 2 more cases where we are looking for the conal. We've done balloon occlusion, and the pressure did not fall. So we realized that, and we talked with our surgeons, and they said that the muscle bundle is basically could be a parietal muscle bundle, which is probably supplied by the conal. If that is hypertrophied, then the conal is the right target. But if it is a septal bundle, then probably we'll have to go through the left septal. So the next case planned is a similar case, and we are going to do a septal balloon occlusion and see if the pressure falls, and maybe even give alcohol in the left septal for that, after doing a myocardial contrast echo in that index patient next week.
Great. Okay, I think we have about 10 minutes left in the transmission. Do you want to show us
how much time we have? I think we've good. So yeah, the IVUS has been done, and I think Sandeep will comment on the IVUS.
Focus on the IVUS, please.
I think the IVUS is is it directly connected? No.
No. It's
okay. Can you focus on the IVUS? Yeah. Yeah, IVUS.
Yeah, run the IVUS. So this is the catheter in the proximal LAD, and we have a drawing from there. There is a calcium, as you can see in the proximal LAD.
ठीक हो दर्द तो नहीं
Again, you can see the calcium in the proximal part of LAD. There's some plaque at the beginning of the LED.
As the circ coming?
Yeah, it's just coming. This is the ostial LED, and now we'll see the circumflex coming at
last angio दोनों दिखा दीजिएगा इसके बाद
10-11 o'clock. This is the left main. So the stent is not there at the level of the bifurcation that we planned that way, and shortly we will see the struts of the stent. So these are the struts of the stent. Overall dia 1, 2, 3, 4 millimeter. We have taken a 4-row stent deployed at 14 to 16 atmosphere. It's a big left main. Yeah.
So we can see the last angio picture also.
Can you show the last 2 runs? So this is the post-IVUS run, wire still in. Just one more shot prior to that. Yeah, this is the heliocaudal.
There's you were pulling back from the LAD, right? The disease in the proximal LAD. What were the minimal areas there? There's a fair amount of plaque burden, much more than I appreciated initially on the angiogram.
How much was the plaque area in the ostial LAD? It was about 3.
Can you show the ostial LAD? Can you show to the...
Yeah, we rerun the IVUS and show it to you.
Can you go to... Can you show the IVUS, please?
Sure. 1, 2.5.
No, this is not ostial LAD.
This is no. This is
There's
just
a plaque at ostial LAD, definitely.
Yeah. At 5 o'clock, 6 o'clock.
Yeah, that's correct.
I'm sorry, I couldn't hear you there. You were saying the IVUS area was what?
At 5, yeah, I think Sandeep, can you go ahead? Yeah. Yeah. Can you see the IVUS? Yeah.
Can you make the IVUS on the big screen, please?
Make it bigger? Yes.
This is the ostium of fluid. Can you stop over here? 1, 2, 3 millimeter lumen.
Perfect. So that is where the plaque is. Can you get us the area here?
Dr. Balram, before we go offline, can you do an IVUS for the circumflex? There's some haziness there.
You have to do it from that side. Pull this horizontal, here, yes.
Yeah, we can do that. We can do that, but we'll give you a better angio picture first. Yeah.
I think the residual lumen is large enough. There's clearly some plaque burden in the LAD, but I don't think that there's significant obstructive disease. I think it is interesting that you placed the stent perfectly. You avoided the origin of the circumflex, so I think the placement was perfect with that shorter stent. It does extend into the ostium by about 1 millimeter or 2. And some people under those circumstances might try to flare the ostium just a bit, just to make sure that subsequent entry into the ostium won't be obstructed by a stent that is out a little bit. It's almost impossible to place the stents perfectly. The ostium usually is oblique. It's not vertical. So any attempt to place it perfectly usually means that you end up missing the ostium. So I think you did a great job. This is a very nice result. I do agree that the proximal circumflex may have some disease in it. I don't think enough disease to treat, but I'm glad that you didn't cover the circumflex with the stent, because I think you've preserved entry into the circumflex if you need to treat it at some point in the future.
Absolutely. I think your suggestion of using smaller than a 12, and I think 12 was probably an error on our side, and your suggestion was absolutely correct of not using a 12. We tried it and you saw that it was clearly going into the circumflex ostium and blocking that. So the 9 probably worked the best.
What will your dual antiplatelet regimen be, and for how long will you continue it in this patient?
On antiplatelets?
Yes. What drugs will you use, and how long will you continue them?
Taking out the wire. Short.
We will continue aspirin clopidogrel probably lifelong for this patient.
65 years.
Shoot.
Do you plan on treating the right coronary at this setting or in a staged fashion?
Circumflex दिखा दो. We could probably do it at this setting.
Go to LEO portal.
And what will your follow-up be? I don't know, Marty, if you have any
comments about that. I agree there is some slight haze in the SIR costume.
That's right. We can handle that.
But follow-up angiograms or a stress test?
Yeah, I think just beyond the circumflex at the bend point.
I think it will be more a clinical follow-up, and we will do an echocardiogram. Because that ostium is very well visualized on the echo in a short axis view. So we'd normally do it like that. We will not do a routine angiogram.
Yes, systematically, in fact, it's almost contraindicated simply to do systematic routine angiographic follow-up unless there's a special clinical circumstance. For an osteo left main, you wouldn't do it. Some people are beginning to think that you can do MSCT. You can see inside the ostium pretty well, and as long as the stent is larger than 3 millimeters and you have modern equipment, you can generally diagnose restenosis pretty easily. But I agree, clinical symptoms, some people would do a stress test. But I would not plan to do a routine angiogram.
Yeah. How much time?
It's a good question about the duration of dual antiplatelet therapy.
Any comments about the other patient?
I think the Brock procedure was...
Any comments on the other procedure? And do you think there is some future for that procedure, for the percutaneous Brock?
I think it's brilliant. I think it's remarkable. I was stunned. Reaching back to my former life when I was doing pediatric work at the NIH, the infundibulum has variable circulation, and I agree. It's not going to be as predictable as alcohol septal ablation for basal hypertrophic obstructive cardiomyopathy. So I think when it involves the parietal wall, and you can demonstrate either by echo contrast that you're clearly supplying that portion of the infundibulum with that conus branch, then I think that it's an interesting procedure for sure. But I'm expecting that you're going to get a variable response due to the nature of the circulatory support of these hypertrophied RV outflow tracts.
Can I say something? Dr. Balram, this is Dr. Somaraju.
I think we've applied for yes, sir.
Congratulations for a very elegant procedure on the RV outflow. But while saying that, we were doing pulmonic stenosis dilatations, and typically this RV pressures going up after the procedures. Surgeons had a term those days. They used to call this ventricle suicidal right ventricle, and but almost all the patients we followed up long term. The infundibular obstructions always came down to less than 40 or so over a period of time. A month time or 4 months time is too early to expect this to fall down. And I could see the heart rates were still high at the time when you were doing the procedure. I think she was not adequately beta blocked. I think good thing for our patients was we didn't know about this procedure at that time. Thank you. I want Dr. Radhakrishna to give his comments.
Yeah,
thank you so much.
The usual practice is probably to wait for...
Most of the time we also do the same, most of the time.
The usual practice is to probably wait for a year before announcing that this is not going to regress. Because many of them, if you look at this thing was followed at All India Institute when we first started the balloon dilatation. And many of these regression of the right ventricular pressure actually started occurring after 6 months. And 1 month could be a bit too early. But as far as this...
I think rather you have a very valid point. But we went back to the surgical papers and we find and talk to the surgeons. They say there is a large element of fibrosis along with some muscle bundle. So and there is a lot of tone in the infundibulum. So the tone part definitely will be taken care of by beta blockers. But I do not know whether beta blockers will cause the muscle to regress really. I mean, if it does, like in LVH with in hypertensive patients with some drugs, I mean, I don't think it is too much.
Yeah. I'm not going against the procedure. I'm just saying it's too early to comment anything.
And similarly, sir,
one case doesn't have any meaning. I think it should be a series of patients, just like in hypertrophic cardiomyopathy.
Yes, absolutely.
Yeah, I agree with you, sir. Like,
absolutely.
Great.
We
thank
take
you
your
so
point.
much.
That is why we wanted to see and get your expert comments on and see what is the future of this project. Thank you.
Thank you so much for a wonderful transmission. I think we're out of time, but thank you again. Those were two wonderful cases.
Thank you, Dr. Balram, for excellent
Thank you
demonstration.
again.
We go on to the next lectures.